Hi, I'm Dr. Newcomb, and today I'll be doing a chalk talk on TOLAC versus VBAC. First, let's start out with definitions. TOLAC stands for Trial of Labor After Cesarean. Note that this is really just a trial, versus a VBAC is a vaginal birth after cesarean. A VBAC is a successful TOLAC. You can also have an unsuccessful VBAC. This is when somebody attempts for vaginal delivery, labors, but still ends up with a cesarean delivery. Let's say that you're seeing somebody in consultation for a TOLAC. Here are the important things to cover in your visit. Number 1, obtain a thorough history. You'll need to obtain her G's and P's, the number of prior C-sections she's had, the type of incision that she may have had, and you need to understand the details of any prior C-sections and their indications. For example, was she preterm? Did she arrest in her labor? Were there any attempts at instrumental deliveries? What was her second stage of labor like? These are all important facts, and if you can't find them from the patient, you should try and obtain records from outside institutions if possible. The next thing to do is to risk stratify your patient. I'll show you how to do this on the following slide. So here's how you can risk stratify your patients into the low risk category, the moderate risk category, and the high risk category. For purposes of illustration, I'll use a little stick figure here. If your patient is in a category where she has had one prior C-section, as depicted here by this stick figure, she would fall into the low risk category. If your patient, depicted here, has 2 prior C-sections, she would fall into the moderate risk category. And lastly, if your patient had anything like a classical incision, a T extension, a J extension, or anything that went into the contractile portion of the uterus, she would be put under the high risk category. These are generally contraindicated for TOLAC. The number 1 predictor of a successful TOLAC is a prior SVD. Here depicted as a little baby coming out vaginally. This is because at that point the mother's pelvis is proven, and this delivery can either be a prior vaginal delivery or a prior VBAC. Other factors can also help categorize your patients. Another is labor course. For example, if someone comes in spontaneous onset of labor, they're more likely to have a successful TOLAC. If somebody comes in and is induced, depicted here by an IV pole, hanging with a bag of Pitocin, IOL, they are moderately likely to be successful in their TOLAC. And in the high-risk category, if your patient arrests in labor, they're definitely high risk. A few other factors that may decrease the probability of a successful TOLAC include advanced maternal age, post-dates pregnancy, mostly as a function of fetal size being greater than about 4,000 grams. Also, obesity of maternal origin. So once you have risk stratified your patient, it's important to give her the predicted success rates and give her your recommendations. For example, if we continue on from the lowest category above, we see that TOLAC is generally recommended. The success rate is quoted at about 60 to 80%, depending on the patient again, and the C-section rate, or the failed TOLAC rate, is quoted about 20 to 40%. The uterine rupture rate in this category lives at about 0.5 to 1%. In the moderate risk category, TOLAC is generally a reasonable thing to recommend. The success rate and the C-section rate are comparable, but in this category, the uterine rupture rate is about 1 to 3%, significantly higher than the prior category. Lastly, in the high-risk category, a TOLAC is generally not recommended or is even contraindicated, as mentioned previously. The uterine rupture rate in this category is 9 to 10%. Now there's one more thing about personalized recommendations for your patient that I'd like to talk about, and this is the MFMU calculator. So this is the MFMU calculator. This gives you a personalized prediction of success based on factors proven to alter the course of TOLAC. This is based on the equation published in the article Development of a Nomogram for Prediction of Vaginal Birth After Cesarean, cited here. It's designed for educational use and is based on a population of women who receive care at the hospitals within the MFMU network. You can see here that they use factors like maternal age, BMI, race, previous vaginal deliveries since last cesarean, and indication for vaginal deliveries or C-sections. All you do is enter in the information for your patient, hit calculate, and you'll be given a personalized prediction of success that you can then quote for your patient and enter into their records. Now I need to make a note on risk. It's important to point out that when we compare risk, we have to compare that of 3 different scenarios. There's VBAC, there's elective repeat cesarean section, and there's failed TOLAC, as defined earlier as those women who labor but end with a cesarean section or a second stage arrest. A VBAC carries less risk than an elective repeat C-section, which carries less risk than a failed TOLAC. So when we compare risk, we're not comparing VBAC versus elective repeat as shown here, because we know a VBAC would win every time. What we're actually comparing is TOLAC versus elective repeat. The reason is because within TOLAC, we know that we have VBAC as a possibility, but you also carry that high risk of the morbid situation we know as failed TOLAC. This is a pretty morbid situation just because the surgery is technically more difficult. The overall risk is high for complications to both mom and baby. So we have to decide, when does the morbidity inherent in TOLAC outweigh that of a repeat section? In general, people say it lives at about the 60% success mark. If you have a 60% predicted success rate or VBAC rate, then the morbidity is generally going to be lower for you to go through with a TOLAC than with an elective repeat section. Again, these recommendations are just generalized recommendations, and institutional practices may vary widely. Now, one last little idea for you before I sign off. Misoprostol, used as a cervical ripening agent in the induction of TOLACers, is totally contraindicated. Consider using mechanical forms of labor induction, such as a Foley bulb or Cook catheter. Also note that oxytocin is generally accepted. That's it for today. Thanks for listening.